I would like to finish off this. Ever since 70s when the endoscopic sinus surgery burst in and the massive cleaner and the Stanford did their phenomenal work, I started doing functional endoscopic sinus surgery to treat chronic rhinosinusitis. It was popularized like anything by the Americans and then followed by all over the world, and here gave redefining results. For the period of time, people realize that in spite of having done a good sinus surgery, people are coming back with the recurrences. Then most of the work in the last 2 decades, most of the work in this field has been done on to understand this pathology, what exactly this pathology is, why it is coming back again and again. We need to know the cause so that we can target our therapy to the cause to treat better. So, what sinus surgery initially was thought of by Stamberger and Satish, that all these major dependent sinuses drain to the ethmoidal pre-chambers. We open up the ethmoidal pre-chambers and we establish the ventilation and drainage to the sinuses and hope for the sinuses mucosa to revert back to normal. And it happens, but this is not all about treatment of this particular disease. So, what exactly is the chronic rhinosinusitis? It is a pure medical disease. Unfortunately, we surgeons try to treat this medical disease always with surgical treatment. Surgery is one of the important aspects of this treatment of this pathology, but purely it's a medical disease. Surgery is a great role. You need to choose when to operate, when not to operate, what kind of disease is, what kind of medical treatment is required. That's what I'm going to talk on. We have reviewed all 3,000 people in the last 15 years to understand this subject, what exactly this disease is, why the people are coming back to the recurrences. This is the exact definition proposed by the American and European Rhinology Society, and this disease is diagnosed mainly on the patient's symptoms. Having one or two major symptoms with the endoscopic confirmation of sinusitis is when it continues for more than 12 weeks, it is labeled as chronic rhinosinusitis. Anything else, there are so many pathology giving the same symptomatology. For many pathologies, the symptomatology is overlapping, it can't be labeled as chronic rhinosinusitis. If you are treating something, the diagnosis should be perfect to get the optimized results. So, this chronic rhinosinusitis by and large divided by two phenotypes. In these two phenotypes, with or without polyposis, this has an immense value because both these diseases are different, they have a different underlying pathophysiology, different treatment, different outcome, different prognosis, everything is different. But this is not all about. Now in the last 2 decades, various endotypes have been described of this disease. The value is the precision medicine. We can't treat every sinusitis on the same line and get the same results. We need to know what kind of particular that patient the disease is living. So there are various endotypes have been described, so you can precisely treat those endotypes on those particular lines with optimized results. So what exactly is this disease? In the next 4 or 5 slides, I'll take you to the molecular level to understand what exactly this disease is. So this is to show our sino-nasal immunity. We are exposed to so many environmental threats, and this burden is taken by our nose. It is exposed to so many toxins, microbes, allergens, so many things every day, and we have our sino-nasal immunity to deal with this, to tackle this, all these threats. And the important part of the sino-nasal immunity is, the first thing is, the most important is the intact sino-nasal epithelium with tight junctions. These are 3 most important slides to understand this entire concept of sinusitis and the treatment. The second part of the immunity or the innate immunity is the mucociliary blanket over the nasal sino-nasal epithelium, which is secreted by the sino-nasal epithelium, and there are cilia which flows towards the nasopharynx. Whatever threat comes to it, trapped by the mucosa and expelled to the nasopharynx and then to the gut. That's how our nasal cavity deals with all these threats. And third one is our sino-nasal epithelium secretes more than 1,000 variety of these antimicrobial proteins, enzymes, opsonins, so many things to deal with all these threats. There are numbers of specific antimicrobial protein enzymes are available or secreted by the sino-nasal epithelium to deal with a particular threat. This is how our sino-nasal immunity works. Now what happens? If the threat is too strong to cause damage to the epithelium in spite of all this, the epithelium has got its own receptors to recognize that threat, and that threat is then passed to the adaptive immunity to tackle the challenge. This is our normal immune system for the sino-nasal system. There are a variety of proteins and things which have been described, thoroughly studied. Deficiency of any of these can cause problem to the patient. That's how these are important things. So now what happens when the pattern recognition receptors detect the threat? It passes on to the adaptive immunity, and this is to tell you simply what exactly the sino-nasal adaptive immunity is. So when the pattern recognition receptors are activated by the threat on the sino-nasal epithelium, there are a variety of cytokines involved in the adaptive immunity, and that's how the targeted therapy is now available. So what are those? The most important being the TSLP. TSLP, interleukin 33 and 25 are the cytokines which are released in response to the pattern recognition receptor stimulation, and that leads to activation of the innate lymphoid cells in the sino-nasal epithelium. These are a part of the immune system, and that has a pivot role in stimulating the T lymphocytes, which are the part of our cell-mediated immunity. Once the T lymphocytes are activated, there are two kinds of system which can be activated: T helper 1 or T helper 2. T helper 1 is activated by a different thread, and T helper 2 by a different thread. And the most important being the T helper 2 system. Once the T helper 2 system is activated, it leads to secretion of variety of cytokines. The most important cytokines being the interleukin 4 and 13, interleukin 5. Once the interleukin 5 is secreted, it leads to eosinophilic activation, and then eosinophils are migrated to the sino-nasal epithelium to tackle the situation, and that by means of secreting basal basic protein gives a lot of damage to the sino-nasal epithelium. And this kind of a cycle, once it starts, it becomes a vicious cycle, keep on giving the damage to the sino-nasal epithelium. Simultaneously, when the interleukin 4 and 13 are secreted by the T helper 2 cells, then the B cells are activated to secrete the IgE, which is responsible for the activation of basophils, and then basophils come to the site of action to further tackle the threat and create a lot of damage. So how the sinusitis take place, this chronic sinusitis take place, this regulation of this innate and adaptive immunity leads to this clinical phenomenon of chronic rhinosinusitis by keep on giving this damage to the sino-nasal epithelium. This is important to understand why I purposely kept it. If we understand this pathway, what is happening, we can tackle this pathway accordingly. So there are so many other hypotheses, I am just skipping them. This is the most accepted one. So what happens if we can stop this cascade at any point of time, we can stop this continuous process of irreversible damage causing chronic rhinosinusitis, and this is the future of treatment of this disease. Surgery is not the future of treatment. Surgery is an important role which I am going to discuss, but this is not all about the treatment. So nowadays the monoclonal antibodies have been developed to target these cytokines. Like for example, if the monoclonal antibody is there with you to target the formation of the activation of the TSLP and interleukin 33, the entire cascade can be stopped. If the monoclonal antibody is available to target the interleukin 4, the T helper 2 cell activation can be stopped at the initial point. Similarly, there are antibodies available to target the interleukin 4 and 13, to target the immunoglobulin E production, to target the interleukin 5, which is most important for the eosinophil activation and recruitment. And if we target it with the monoclonal antibodies, we can stop this entire system of giving this irreversible phenomena of CRS. And that's how the targeted therapy is coming, which has now been approved by the US FDA to be used in the clinical situation, not in our country, and this is going to be the future of the treatment of this particular disease. So like we have now anti-IgE antibody, which is known as omalizumab, which is being marketed by the Sanofi Aventis. Not in India, it's soon it's going to be in India. Anti-interleukin 5 antibody like mepolizumab is being marketed by the GSK. Like so many antibodies are available, target this CRS cascade. And if you target this cascade, the whole phenomena can be stopped. There is a myth amongst the physicians, the surgeons, and the name implies the chronic rhinosinusitis. It looks like an infective pathology. Mind it, this is not an infection at all. This is inflammatory disease where the treatment of choice is target this cascade pathway, not any infection. Infection is not the cause of this disease. Infection just can be a disease modifier by targeting the innate immunity. So anything which targets the immune system, which improves the immunity system, is going to be the treatment for this. Anything which lowers the immune status by targeting the innate and immunity is going to affect the outcome of these patients. So what lies in the immune system, innate and adaptive immunity? Like for example, any genetic defect in the mucociliary system, like cystic fibrosis, how does it happen? The chloride transport is affected and the thick viscid secretions are formed, which cannot expel cannot serve the same mucociliary function to target the environmental pathogens. So anything affecting the immune system is going to worsen the situation. Anything improving the immune system is going to give a good result to the patient. The target is that, not the infection, not the surgery. Surgery is a role which we are going to cover. So how to diagnose this situation? Normally, what we do, we get the endoscopy, get a CT scan and refer the patient for surgery. We see opacity on the CT scan, see polyp on endoscopy, that's the patient for surgery. It's not like this. The reason being, why we started looking into this subject, even if you do a good sinus surgery, for the period of time you see the patient coming back to the same polyp, same sinusitis picture in spite of having a full surgical block. So we need to target the pathology, which is the inflammatory pathology. So once it comes to CT scan, we'll discuss intraoperatively about the scan. There are certain other investigations which are important to know the extent of disease. This is an inflammatory disease and we need to know the inflammatory burden of the patient to tell him what kind of disease you are having, what kind of treatment you need, and what is going to be the outcome of the treatment, what is going to be the length of the treatment. Suppose you operate a patient, the indication of surgery I am going to discuss after this slide. If you operate your patient, the patient will have the first question, doctor, will this disease come back again? 100% it is going to come back if you don't target the underlying pathology. And to know the underlying pathology, you need this investigation. Like for example, eosinophilia has a pivotal role in pathogenesis of this disease, which causes a major damage to the sino-nasal epithelium. If the patient has severe eosinophilia, you need to tell them beforehand, you have a significant eosinophilia which requires treatment later on. If you are operating on that patient with a polyp and have this information of the eosinophilia, you have to tell him you need long-term steroid irrigation for the future for prevention of this disease. Otherwise, you have a high chances of this disease coming. Like suppose you have serum IgE level very high, that goes in favor of some sort of hypersensitivity that could be having associated allergic rhinitis or anything other allergy to the patient giving rise to the high IgE. If we ignore these facts, we operate upon a patient with a high IgE, it is going to be a problem in the future. The same symptoms of allergic rhinitis, symptoms are overlapping and then the patient will assume that the surgery is gone failure. So we need to know each and every aspect. I am going to discuss later on about the immune aspect and the aspirin sensitivity and all these things. But each and every investigation, there is a routine protocol proposed by the American Rhinology Society for the workup of every patient who is labeled as a chronic rhinosinusitis to know the inflammatory load. Now, vitamin D, as I mentioned, is the most important immunomodulatory hormone for the sino-nasal epithelium, and it serves a lot of functions. At the same time, we saw the cascade of the chronic rhinosinusitis development, and it stopped the cascade at various levels if the patient has a sufficient vitamin D level. If there is deficiency, it works at various levels to worsen the situation of the immune regulation, and at the same time it decreases the sensitivity to the corticosteroids if it is deficient. So the vitamin D is very, very important, and we have seen in our practice. I showed you that last slide of what investigations are required in every case. I have seen in the practice patient having severely vitamin D deficiency having worst outcome. You replenish the vitamin D and the patient works better as you improve your immune system. This is the histopathology report I will discuss later. So now, why I showed all this cascade and all this. So now we can know what can be the management of this situation. Now, if the patients, you saw the cascade at every level, whether interleukin 4, interleukin 5, IgE, every cytokine is suppressed by the steroid. You give the steroid, it works at every level, but you know how long you can give steroid. So treatment of choice, at present the weapon we have is the steroid. Any patient coming to you with sinusitis, with a polyp, give him a course of steroid for 10 days, 15 days, he will come back to you being grateful, doctor, what have you given me? Dr. X has advised me surgery and you are magic. You have done magic, you have given me the best medicine, I am doing very well. Please continue on this. We all know how long we can continue with oral steroids. They have got their own adverse effects. We can't continue for long. But yes, it works at every level of the CRS cascade. So the treatment is the corticosteroids, but because of the limitations, we can't continue the oral corticosteroids for long. So the only weapon left to us is topical corticosteroids. Now the disease, the basic root of the disease is in the sino-nasal epithelium. The epithelium or the mucosa of the paranasal sinuses from where the polyps are coming. When you use the topical steroids in the pre-operative, non-operative setting, these steroid sprays do not penetrate beyond the anterior 1/3 of the nasal cavity. So how will they penetrate the paranasal sinuses? So if you are a patient with a high inflammatory load, where the oral steroids work, oral you can't give for long, you are using topicals, it will not be able to handle or tackle that inflammatory load. So the other option that you have is endoscopic sinus surgery. So we need to understand those people who have a very high inflammatory load, where the medical treatment is not responding. Medical treatment is topical steroids. Then the role of the surgery comes. And surgery has a clear-cut indications and a clear-cut role. What will you achieve with the surgery? You open up the sinuses, establish the ventilation and drainage. That's important. The role of surgery is mainly to reduce the inflammatory load, all those polypoidal tissue and the material. You remove everything so that the patient can start again responding, having the lower inflammatory load to the topical steroid. Now the most important advantage of the surgery is in the non-operative setting, the only steroid weapon you could use was a topical spray, which could not penetrate beyond anterior 1/3 of the nasal cavity. Now having done the sinus surgery, all sinuses are opened or exposed. Now you can irrigate deep into the sinus into the topical steroid solution. Now when the topical steroid reaches deep into the sinus mucosa, it works like magic. So the role of surgery is now redefined. Role of surgery to reduce the inflammatory load which is not being taken initially by the topical steroid in the non-operative setting, at the same time giving access to the topical steroid deep into the sinuses for the post-operative treatment. So now we have to convince a patient in a different way. Patient coming with a polyp saying that we'll operate, you will be alright, is the biggest joke to the patient. You have to tell them you have a medical disease, the treatment is steroid, we have the limitation, we can't use oral steroids for long. We can use topicals, but topicals are not reaching to the target area. So to make the topical steroid reaching, to make the medical treatment effective, we have to open up your sinuses. And then you have to use the medical treatment. So now the patient will ask how long I have to use the medication or the topical steroids in the future. That depends on your inflammatory load. That's why this initial list of investigation is important. If the patient has a severe eosinophilia, you need to tell them in advance that you will need long-term irrigation to prevent the disease coming back. So this is very important. If you understand this philosophy, you can explain the patient in the same way and the patient will understand. And the role of surgery is to make the medical treatment effective, to make the steroid reaching into the sinuses, not to cure you. Surgery is not like fail or pass. It has an important role to make the medical treatment topical steroid effective. Now you can deliver high dose topical steroid deep into the sinuses, yet without systemic side effect, which was not possible without surgery. So like how this counseling is like, if the patient goes to the cardiologist and some cardiac stent is required, the first thing they tell you, You need a stent to open up your vessel, but to keep it patent, you need to take aspirin lifetime. Otherwise, it will get clogged. And no one patient having stented will dare to stop the aspirin after having explained this fact. We need to explain our patients the surgery has a role to make the medical treatment effective, to make the penetration of steroid deep into the sinuses is not the deep treatment for everything. And if you continue with the irrigations and stay in the follow-up according to the situation now, clinically, in the future, according to the nasal endoscopy finding the patient is doing well, you can reduce the concentration of the topical steroid, you can reduce the frequency, or you can even afford to stop it according to the situation. If it starts coming back, you can restart the irrigation once your sinuses are open. This way, you can indirectly guarantee your patient that yes, the patient's first question is, will it come back? Will I need surgery in the future also? I have heard that this sinus disease comes back again and again. I will need repeated surgeries. You have to explaining the role of surgeries to make the medical treatment effective. And if you are in follow-up and take the irrigations, the sino-nasal steroid irrigation in the future properly, hopefully this disease will not come back. This is sort of the direct guarantee you can take. This is the basic philosophy behind the management of the chronic sinusitis. But there are lots of variants of this. It's not all about all diseases same. There are variants that the patient is aspirin sensitive, he has a different pathology, he do a lot of different things. So this was to tell what exactly this disease is. Now, we always have been told the role of sinus surgery comes when the medical treatment fails. So what should be the appropriate medical treatment? Earlier the terminology was a maximal medical treatment. It now has been changed by the American Rhinology Society as the appropriate medical treatment. So for the polyposis disease, the appropriate treatment as a sort of guidelines, like Dr. Haldipur was yesterday discussing, to formulate some guidelines for the junior colleagues so that we can uniformly treat our patients and get optimized results. So for the polypoidal patient, the appropriate medical therapy is saline irrigation and corticosteroids. Saline irrigation is a very, very important role. You have to ask your patient to irrigate with a high pressure rubber ball with a saline to rinse the nose to remove all the inflammatory mediators, allergen, toxin material, and to remove the mucosal edema and improve the mucociliary clearance, to improve our innate immunity. Mucociliary clearance is a part of innate immunity. So the main weapon for the medical treatment for with polyposis or without polyposis is saline irrigation and topical steroids. For the polypoidal disease, we can give short perturbation of the symptoms, a short course of steroid as it works. And now it has been proven in the recent guideline, doxycycline works with the magic for the polypoidal patient, as it works at every level of the Th2 helper cytokine cascade to reduce the levels of the cytokines involved in the polyposis formation. Our protocol is to give doxycycline 100 mg dose for at least 3 weeks, and it works very well to reduce the inflammatory burden, which can be taken by the saline irrigation with topical steroid in some patients, only without the need of surgery. And montelukast, we will discuss later why it is important. For the polypoidal, non-polypoidal disease, the mainstay of treatment is saline irrigation and corticosteroids. And another thing which is very, very important nowadays is, of course, the non-polypoidal disease is a neutrophilic driven disease. Antibiotics, short courses of antibiotics work with situation of exacerbation. But now the biggest role has come in is the role of macrolides in the low doses, which works as immunomodulators only for the non-polypoidal disease. Antifungals is anywhere in this entire scenario of chronic rhinosinusitis signs. Antifungals have no role, and there is no point in giving antifungal unless. Yeah, that's how I'm coming to. I said that's an important point from you. So I skip all this because of the time constraint. Yes. So like what Arshad asked, how long the macrolides and what macrolides they should use. First of all, what does macrolide do? It works in the T helper cell system, one system, which gives rise to the non-polypoidal sinusitis, and it works at every level to combat the sinusitis, the CRS cascade, in this entire science of development of chronic rhinosinusitis without polyposis. Clarithromycin is the most suited one. There's lots of trials, more than 500 trials so far have been done with the macrolides. You have to use in the low doses, like clarithromycin you use at a 250 milligram a day for minimum 3 months, and it reduces the cytokine level to the level that more than 70% of the patients without polypoid disease can be taken up with this medical management without the need of unnecessary surgery. And like you said, when to give. This macrolide system works on the T helper 1 system. So whenever there is high IgE, there is no point in giving macrolide. Patients who are highly allergic do not respond to macrolide. So this is selective for the patients who have either normal or low IgE, where this macrolide can be selectively used, and this works very well. So now, once we talk of this disease, it's not a single disease, it's like a syndrome. We need to handle it or deal with like any other syndrome. There are lots of comorbidities which complicate the situation if that is not addressed. Like for example, more than 2/3 of the patients have associated allergic rhinitis. And we don't address the allergy and operate the patient in the post-op patient will come back with almost similar overlapping symptoms. After I have a running nose, I have a blocked nose, I have a feeling of headache, sneezing, I think my operation is gone failure. And that will keep bothering again and again. We all know allergy is an immune complex disease, that's a different systemic disease, and if it is associated, it has to be tackled, otherwise it's complicated. Similarly, smoking. Smoking is one of the negative factors for the CRS patient. It works by many means, you can read out here. And it impairs our innate immunity system and prevents helping the patient to recover from disease in spite of the best treatment we offer. So we need to tell our patient, counsel them if you want good results, you need to quit smoking, otherwise you cannot get the expected results what you are otherwise expect from this treatment. The most important thing is, about this entire thing is, this impairs the alpha hydroxylase level in the nasal secretions. Alpha hydroxylase is the most important enzyme involved in the activation of the inactive form of vitamin D to the active form of vitamin D. And in smokers, this is impaired, and you will find a significantly low levels of vitamin D, particularly in the smokers, which is an important part in the sino-nasal immunity. Immunodeficiency. See, many a times, 10 times, 5 minutes. So many times we do a good work in spite of having done the entire workup, good surgery done, good post-operative treatment, don't get the desired result. And that's the reason which we often overlook, immunodeficiency. 5 to 10% of the patients have some sort of immunodeficiency because it's an immune complex disease, and we should not overlook such patients who are not responding to the treatment. And we should discuss with our immunologist and work up for the immune system, and that has to be corrected to get the optimized result. We have many times sent our patients who have low subclass IgG deficiency and sent for the immunoglobulin replacement therapy. They need more culture-directed antibiotics to prevent the situation of the infection, and the organ transplant is on so many diabetes. Even the diabetic patients have different overall outcome as compared to non-diabetic. Another subset of diseases serve the most advanced aspect of this chronic rhinosinusitis. Highest inflammatory load of chronic rhinosinusitis you get in this particular subset of this disease, that is aspirin-exacerbated respiratory disease. We have done a patient last month in the Delhi workshop. The patient operated 19 times for sinuses. When I went there for the workshop, I asked them to get the list of investigations which we have proposed done. You won't believe he was severely vitamin D deficient, less than 3. He was significantly sensitive to the aspirin. The moment we gave them an aspirin testing, supposed to develop severe asthma. And if these two things are not taken care of before operating, you operate him 100 times, it's not going to respond. The disease is going to come back. We need to target the inflammatory pathology, otherwise you can't get it. Aspirin-sensitive disease is a different disease. Nowadays, so far we have more than now 300 patients who have been desensitized with aspirin. That's an important part of the management. how can we overlook the original inflammatory pathophysiology of the patient and treat that patient surgically with the polymer? If the original pathophysiology is not targeted, there is no point in expecting good results. What is aspirin trying to be? Quickly, in our body cells, the retinoid acid is metabolized preferentially by the cyclooxygenase enzyme into the prostaglandins, which are anti-inflammatory agents. At the same time, it is metabolized into the leukotrienes by the lipoxygenase enzyme. And once this pathway goes normal, the production of the prostaglandins, which are anti-inflammatory, that suppresses the lipoxygenase to produce the leukotrienes less in number. Leukotrienes are pro-inflammatory. So normal homeostasis, the leukotrienes are produced very less and the prostaglandins are produced in abundance to keep the patient without inflammation. Now what happens if what is aspirin? Aspirin is a COX-1 inhibitor. If the patient is sensitive to the COX-1 inhibitor, COX-1 is cyclooxygenase. In one inhibitor, aspirin, the prostaglandin formation is stopped. Inhibition of the leukotriene formation is stopped by removal of the prostaglandins, and the leukotriene forms in abundance, which are pro-inflammatory agents, which give a lot of things like vasodilation, true muscle contraction, excess glucose production, and leads to the situation of this respiratory disease affecting the upper as well as lower respiratory. This is the highest spectrum of this inflammatory load in chronic sinusitis. And if this pathway is not targeted, you may operate patient 100 times, not get released again, come back again with the same disease. So, what you have to do, you have to target this pathway. And what all you can do is, you have to remove the inflammatory load by doing a complete bilateral full house test so that you can eliminate the steroids, and then give xylitol with a 5-lipoxygenase inhibitor and leukotriene antagonist like montelukast to treat the patient in the post-operative period. But the most important aspect is to desensitize from the aspirin. So again the COX-1 starts working. So how the COX-1 is going to? Yes. So that's a very important mechanism. You need to tell your patient, you need to get in the post-operative setting. We do it. Since we start aspirin, we don't start it pre-operatively, otherwise we can't operate on the patient on the platelet problem. We start this after 4 to 6 weeks and the cavity has a good healing in place, and you have to get the patient admitted in the ICU setting, because you have to start with the aspirin, oral aspirin dose in the low doses, and the patient even in the low doses may develop severe asthma or status asthmaticus. It should be done in the ICU setting with a patient having under montelukast cover for 7 days with a good baseline FEV1, and then start this aspirin sensitivity aspirin and keep it increasing every 3 hours from 30 mg to 330 mg. Once patient start tolerating low dose, he will tolerate the high dose. Once he starts tolerating aspirin, taking aspirin every day, the prostaglandin will again start forming, leukotriene will stop, and disease will reverse like anything, and then you realize why you are operating again and again in the patient. This is a very, very important aspect. Biofilms are important. The last which again, if overlooked, affects our optimization of the results in sinus surgery. Biofilms are what? These are aggregates of bacteria which develop on the sino-nasal mucosal surface, and it is surrounded, these aggregates of bacteria surrounded by the proteoglycan matrix, which resists for the treatment by the patient immune system, by the antibiotics. Nothing works on the biofilms that protects from everything. So you need to have a lot of other strategy to tackle with the biofilms. We have tried all these, but recently in the present situation we are using only 4 things to deal with this. The diagnosis of biofilms is important. We need to get HME stain and culture sensitivity. The ideal diagnostic tool is not available in the clinical setting, which is a laser microscopy, which is not available. What you have to rely on is repeated culture sensitivity and the HME stain to find the biofilm. So what we have been doing with the pseudomonas biofilm, our target, the main weapon is the tautomycin solution. If it is a Staph aureus biofilm, it's a buprenorphine indication. Buprenorphine is not available in the powder form in the clinical setting. So all we have in the form of buprenorphine is the oil-based cream, which can be dissolved in the normal saline. So we have to buy the buprenorphine For the manufacturer in the powder form is the most expensive agent out of all this. Because 1 kg of microcin costs more than 2 lakhs. And here to give a consideration for the topical irrigation, 5 milligram per 100 ml. And if you irrigate topically, the biofilm respond like anything. If you use systemic antibiotic, in spite of having given 1000 times concentration, it is not going to affect the biofilm bacteria. It's a topical which works better. Colloid silver is freely available now, and it's not in the medical approved by the pharmaceutical industry. It is available on the Amazon, and we talk to tell our patients buy it from the Amazon. It's not expensive. Silver is one of the most strong antibiotics we know for centuries, and this silver in the nasal spray form works on each and every bacteria. And the last and the most potent one is the Manuka honey, which we bought from New Zealand. This is a special product which is the most strong anti-biofilm agent, which is derived from a special tree in New Zealand and marketed by only one company in the world, which is approved for this medical grade product for the marketing and use. That is Watson and Hill Laboratory. It's expensive, 250 milligram per 15,000, but it works like anything if you go for topical irrigation with this. Don't need any antibiotic at all in sinus surgery. Antibiotic rather suppress the normal microbial flora, which is protecting us from the pathogens. So it complicates the situation if you use oral antibiotics. Use topicals to target the pathogens if they are biofilm to the silver spray which is available for CITs. So I will skip all this because of the time constraints, and thank you Madhu so much for giving me the opportunity.
Thank you, Satish. I made this lecture specially for all the postgraduate because chronic sinusitis is an enigma.